Hello, this is the front desk.
Good morning and welcome to episode 77 of the Crackenbacks podcast with your hosts, Dr. Terry Wyman and Dr. Spencer Barron. How you doing this morning, guys?
Great to see you guys, as always.
Good, Lance. Good to see you, my man.
It's great to hear. So today we are joined by Dr. Joe Verna. Dr. Verna is the Chief Operating Officer for Measurement Driven Rehabilitation Systems Incorporated, a licensed chiropractor, a qualified medical evaluator, and a certified industrial injury evaluator and independent medical examiner for the state of California. His professional experience has included consulting in the fields of industrial medicine, functional capacity assessments, and spinal rehabilitation, injury prevention, and risk management. Good Lord, that's a lot of titles. How you doing this morning, Verna?
Thanks for having me. I'm excited about that. Hey, you asked for a bio, so we put one together.
Yes, we did. Hey,
it's a big one.
So last night I'm throwing axes, drinking bourbon with a friend, a long time friend of mine, physical therapist, Dr. Eric Humbo, and we were kind of chatting, and it came up, about this company that he just got acquired by, which is Spine and Sport. And from what I gather, and I started doing a little research, it's a nonprofit research company, but it's also buying up clinics. Can you explain how this all works?
Yeah, actually, no. There's confusion because the names are very similar. So on the bio, if he would have kept reading the bio, he only had half an hour, right? I also run a nonprofit research foundation. That is separate from Spine and Sport. That's the research foundation is U.S. Spine and Sport Foundation.
Okay.
And there we have a PhD who happens to be a chiropractor, Dr. John Mayer, not the singer. And John Mayer has a bio that's 10 times longer than mine. He's actually a world-renowned researcher, and he specializes in injury prevention, and he's been involved with FEMA and Homeland Security with first responders, primarily firefighters, and also with the Department of Defense. So the foundation is different, although we are very friendly and we interact with Spine and Sport, the office that owns the physical therapy, or the entity that owns the physical therapy.
Got it.
So let me ask you though, because I would love to really get clarity on how a chiropractor, and what was your early years as a chiropractor like, transitioned into this business entity and corporate structure.
Yeah, so it's interesting. When I first came out of school, we were promised like, oh, you're going to be the gatekeeper. And boy, I got out of school and I got hit in the head with a 2x4. And I didn't want to do a traditional chiro cash practice, not because it's wrong or there's something wrong with it. It just wasn't for me. And so what I looked at is, what is a pool of patients that I can actually make an impact and earn a living? And early on, I started doing injury prevention and getting into LA County Fire. I had the practice in Brea. I had my associateship with somebody, and I basically rented space and had like no income for 2 years. My wife supported me for 2 years, and just started marketing. And I was fortunate to get into LAPD. I became a consultant there, so I volunteered at the LAPD for 10 years, and eventually, they started driving business and also LA County Fire. And then I got into marketing insurance companies from there, and also medical doctors. And that, 30 years ago, that was pretty different, right? Now we have a better relationship, which is good, right? And so I really got into the multidisciplinary approach, and I did really well in Brea. But then in 1999, right around 98, I met this doctor, Dr. Vert Mooney, who was a world-renowned surgeon and researcher. He developed arthroscopic procedures. He's one of the first ones to do arthroscopic surgery. Was probably the largest innovation in orthopedic surgery. He was a professor at UCSD at the time. And he was disillusioned because the universities take a big chunk of money whenever you get grants and they use it for what they want. He was bringing a lot of money, wanted to do his own research foundation. And so we started the physical therapy company, which was multidisciplinary at that time, spine and sport, to help fund research. And so that's how I kind of got into that. And then the corporate world kind of developed as we grew. We started with, we started with 3 clinics we purchased in Tennessee to then opening a clinic in Kearney Mesa in 1999. And as of today, we have 41 clinics. Unfortunately, Dr. Mooney passed away, but we still have some high-powered individuals on the foundation, like Leonard Matheson, who's developed the Quick Dash and helped develop photo and is kind of the grandfather of FCs and functional capacity. So I don't know. I think I got really lucky to be around people that were really open-minded and didn't mind working with a chiropractor. They saw value. And I think Vert told me early on, it doesn't really matter what discipline you are. There's going to be outliers, good, bad, and evil, and everything. And sure enough, it worked out.
That is a highlighted comment due to the fact that, I call it professional prejudice. There's, people that you say you're a chiropractor, especially in the allied healthcare profession, and they go, "Oh, you're a chiropractor." It doesn't exist as much as it did 30 years ago. But that was really an important point, especially coming from someone as prolific as was it Dr. Mooney that said that? Is that
Dr. Mooney told me he didn't. At Rancho Los Amigos, I'll tell you a real quick anecdote. If I can start boring, let me know. But he was a maverick surgeon. He really, his mentor invented arthroscopic surgery. I mean, he really did, if you trace it back. And he started doing surgeries at Rancho Los Amigos to impress his colleague who invented arthroscopic surgery. So that was his mentor. And remember at the time, we didn't have biologic drugs for rheumatoid arthritis. And remember, there was a lot of deformities for hands. So he became a maverick hand surgeon. So he was doing all these crazy surgeries on the patients at Rancho Los Amigos in LA. And so his mentor came by to see what was going on. And so he was, I'm hot. Wow, I'm really good at these, and showing him how great the surgeries were. And in front of all this crowd, the MD said, "Well, can the patient prone?" And he goes, "I don't know. Can he lay on their stomach?" Because the life expectancy was much higher if they could lay on their stomach and move around if we have severe rheumatoid, right? And so nobody knew, and then the physical therapist didn't know. The occupational therapist didn't know. You know who knew the answer? The orderly.
Oh, wow.
And so that's how he started doing ground rounds, including the orderly, because the orderly knew when the patients moved, how many times they went to the bathroom, they knew everything. And so what he got in his mind is that everybody's an important part of the team. So whether you're a chiropractor, whether you're a PT, whether you're an exercise physiologist, I love working with athletic trainers. I learned a lot from physical therapists. I learned a lot from different chiropractors, medical doctors. And of course, you're going to find the one that I've walked into offices and told me to leave, right? Or told me I didn't know Vert Mooney. I had a guy in Beverly Hills tell me that, "You don't know Vert Mooney." I go, "I'm his associate. I work with him. I'm a partner." "That's impossible." I said, "Here's his cell number. Let's call him." So, and at that point, you just don't care anymore. I just focus on what's important for the patients and for the community, and let's move forward.
That's a fantastic story, because it really elevates the profession in a sense that when don't you ever notice that at that level, when somebody like orthopedic or neurosurgeons, when they're that confident of their work and their abilities, suddenly they're more open-minded and capable of working well in the sandbox together, or playing well in the sandbox together.
That's exactly it. He was very humble. And then I was fortunate too to work with Robin McKenzie. So, Vert was very good friends with Robin and was in the Institute. So we collaborated quite a bit. And so I'd go to dinners and, we'd work together on papers with Robin. And that's what I found too. Everybody thinks the perception is, oh, McKinsey's, they're like this, McKinseyite. Oh, it's extension. And what I found, he was nothing like that. He could care less. We would talk, and in those days I was full of vinegar and wanted to prove my point, and very loud. And he would just go, oh, "That's great, Joe. Do what you want to do. If that patient, you're doing that with a patient, go ahead." They were so secure, and I, all my life I've been trying to get to that level. I'm not there yet.
Well, what's interesting, Joe, is that I use a metaphor that you will definitely be able to embrace deeply. And that is, when you're a black belt, as you are, right? You don't go around kicking everybody's ass. You have a personal power about you. Now, if you're a white belt, you want to try it out. You want to, pick fights with people. So it's really a metaphor that I use for the medical profession. When you're at that level, you're humble. When you're just starting out, you have prejudice, and so it's a beautiful example.
Yeah, no,
which is what you do.
That metaphor rings, and that's what I teach my kids. And, I was involved in mixed martial arts for, 25 years, and I'm lucky to be alive. And it really humbled me because eventually you're going to find several people that are faster and better than you are. And the best thing to do is avoid the fight. And if you have to fight, you better end it quickly at my age. But no, that's exactly the metaphor that I use. Yeah. Absolutely.
That's Spencer's favorite metaphor.
It is.
It's a good one, and I'm telling you, it's true. And
yeah,
you'd be surprised how many times you just turn the other cheek, and the other person has no idea how lucky they were, really.
Hey, that's Joe, right. Looking at your business model for Spine Sports, is there a reason that you're going after like a lot more PT clinics and you're not integrating chiropractors into them?
Well, we have leasing space into the clinic that I have. I still have a pretty large med legal practice, and we do have some athletes and some patients, some mixed martial artists I used to treat. And Dr. Michael Hupka runs that practice there, and that's at Kearney. But we tried, and I'm not saying it's impossible if somebody else would like to try it. But we truly had a multidisciplinary practice, but we didn't do it because of financial gains. Mooney was a multi-millionaire when he passed away, but he wasn't about the money. He was very humble, and we did it because if the patient needed manipulation and chiro care, they would see me, or we had two other chiropractors at the time. If they needed physical therapy, the chiropractor would refer them to physical therapy. Everybody got paid a salary. Nobody got paid more for seeing more patients at their own practice. Dr. Mooney didn't take a salary. He donated his entire salary to the foundation. And so when he passed away, I really tried to replicate the model, but I couldn't find anybody. Number one, find a surgeon that's not going to take a salary. That's not going to happen. But, most of us are selfish, right? We want to make more. We want to do more. And that wasn't the intent. And then that's why I think it was very different than most multidisciplinary practice. And I'm not saying all, but many are set up to drive more revenue, right? And this wasn't a revenue scheme. This was basically trying to do something different.
Are you guys heavily insured? I imagine you're heavily insurance-based versus, and do you have cash-based systems in place?
The cash-based and for the direct, for the physical therapy, there's direct access, but in California, it's limited, and it hasn't really taken off. And I also think that the APTA did a poor job of advertising by, putting it behind buses saying, "Hey, don't see your doctor, see us directly." Yeah, that's going to go well. I've always worked with the doctors and formed a good relationship. And that seems to work a lot better. So we do have a very small cash, but that would not do it. Then we have substantial Medicare, and it's different. And unfortunately, that's where it's really prejudicial to us as chiropractors because we don't get paid well in Medicare. And I've provided exercises and strengthening, particularly for spine, isolated strengthening when I do manipulation, and Medicare doesn't pay for that. And many insurances don't pay for that. And I think that's the kind of our Achilles heel is that we haven't had enough lobbying to be at the par with that. So for the physical therapy, we get paid well for Medicare. We also do a lot of workers' comp. That's my specialty. Now, chiros who stayed in work comp are being paid very well now. And so I would
Even in
really,
California?
in California, yes. For a med legal evaluation, the minimal fee for a qualified medical evaluation is $2,000 for that evaluation. And we've had some that we've billed up to $6,000, $7,000, $8,000 because of the record review and the complexity. So California, the pendulum switched back, and so it pays very well. It actually pays better for chiropractors than physical therapists.
No kidding. Well, Joe, we're going to have to talk a little bit more because I just got paid on a claim for the first time. It was a work comp claim out of California, a former LA Raiders, it was Oakland Raiders guy, that NFL guy that had a settlement that, that work comp will continue paying.
Future medical?
Yeah, and I got $39 for therapy or for like neuromuscular work and $0 for the chiropractic adjustment. So I must be doing something wrong. So
yeah, no, that's because typically it's time based, right? So you could do the chiropractic adjustment, right, and then whatever other procedure codes, CPT codes.
Yeah,
and typically you should be within $200 or more.
Oh my gosh. Well, we'll talk after the show.
Absolutely.
Thanks. So another question would be, you obviously do, even with cash patients, you do more than what you're paid for, which is a beautiful thing. So, but allow me to ask you, what is like the triage when a new patient walks in? Where do they go first? Do you have an algorithm that obviously you do? What would that be?
The chiro's separate. So for the chiro, I'm sorry, it's always confusing. It's always been confusing to explain this practice. But for the chiro, they see the chiropractor first, right? And so they're either going to be referred by an insurance company. You're in the medical provider network if it's a work comp patient, right? So in California, you have to be within that medical provider network. And then they'll see the chiro, and typically we do a history and assessment, and then we phase the patient into what phase of care they're in. So phase one would be, and that, by the way, it's the same for physical therapy. Phase one would be acute, so you're within the less than 6 weeks of an injury. You're going to require more manipulation, more hands-on, less strenuous exercises, right? Phase two, you kind of know what the direction is. So if you're a McKinsey person, directional preference, they're centralized from pain, and you can do more things with them in phase two. You could be doing manipulation, but you're probably going to start weaning down. It's not going to be 3 times a week. And then in phase three, we load them. So that's one of the things that we do quite differently. Even the chiro is training that is when it's phase three and it's something chronic beyond 3 months, we may do 1 or 2 visits to look at stability, but then we're going to load the spine with weight. And we do that through different methodologies. And we publish quite a bit of research on that subject. Nice. So high intensity training for the lower back and the neck is something that's been going on for 30 years, but finally now the literature is catching up to our crazy idea. And actually it was Vert who, again, at Rancho Los Amigos, noticed that if he sent the spine patient out, chronic back pain, to a physical therapist, it was very inconsistent results. If he sent the shoulder or knee, they're very consistent results. But when he sent out the spine patient to different therapists, it depended on a lot of beliefs, wives' tales, different things. And I would tell you that it's the same in all professions. We were initially taught to immobilize the neck and the back.
Yeah.
Right. But as chiropractors, we're doing manipulation, so aren't we moving it? But then we're afraid to load it with weight, right? And again, if you were in the martial arts, I bet you worked out your neck, didn't you?
Yeah.
Yet on patients, show me somebody that works out the neck with weight, not with a TheraBand, not with a ball. That's phase 2. That's appropriate for lower level. But when you get to a higher level of chronic, remember the multifidus shut down. And we've done quite a lot of research with that. And if you don't work that out, you get fatty infiltration and chronic disability in the spine. And you can reverse that with exercise, but you have to load with weight.
Now, how do you mean? I'm just curious. Again, we have viewers and listeners out there. So for the listeners, when you load weight, people, I don't want them to say, "Oh, maybe I should start doing heavy squats." So what are you thinking behind that whole process?
Well, you can do it different ways. So once you know the principle, you can start out with really light weight and then increase it progressively. So for example, all the clinics in San Diego, we have specialized equipment called MedX, which you can load very systematically. It's very safe. The problem with that, it's extremely expensive and it takes up a big floor plan, and it's probably not the most practical. You're sitting in the darn thing. That's not very functional, right? But we have done a lot of research, and in the clinics in San Diego, we purchased all that equipment and it works really well. Secondarily, though, you can do lesser things. Like we invented a variable angle Roman chair that you can progressively increase resistance with weight over time, right? So it goes from vertical for the lower back to horizontal. And as you go through, and that was published in Spine, several publications in Spine and Spine Journal, and has probably 25 publications. And that's semi-functional. Again, it's a machine. And then number 2, if you don't have the means or money, you can get harnesses for the neck. You can look it up on Amazon. You put harnesses and you can start with very small weights. Right now, anybody listening to this podcast, again, go into boxers, martial artists, wrestlers, football players. They all work out their necks and they're not dead. They're doing very well. They don't get injured, right? And they have less concussions. And you can see Floyd Mayweather. I don't particularly like him, but he's never been knocked out. And he works out his neck like crazy. YouTube Floyd Mayweather or Canelo. Canelo's more popular now. I like him, the boxer. Look how they work out their necks. And you can do that easily with patients. For the lower back, you could do good mornings with very light weight and progress them. You could do kettlebell training. Kettlebells appear to be more functional than other means. And you just progress it very slowly. And you can add maybe 1 to 10% per ACSM guidelines of weight and do 15 to 25 reps. I wouldn't do more than twice a week because you need recovery time. Because their back and their neck is going to burn, just like if you had a really isolated biceps workout. You're going to feel the burn. And I tell them that's what we want. That's what we need.
Joe, I love what you're saying. To really, again, highlight an aspect of what you said about strengthening the neck and reducing the potential for concussion ramifications. There was actually a factor of for every pound that you increase in neck strength, it's a reduction of about 5% of what circumstances that can occur from a concussion. In other words, you reduce your potential for greater injury. And, just to thank you for sharing, a protocol, because I think that's so important, especially for treating cervical spine and low back injuries.
And it works really well with manipulation. There's research showing that it works really well. As a matter of fact, higher results if you combine it with manipulation, which is really exciting for us, chiros.
So good.
Thank you for sharing that, because I think that's extremely important, especially for athletes that deal with those kind of body blows or head injuries.
Heck, for the desk jockey, the executive that sits at a desk with his neck frozen all day, it's perfect for that too.
Yeah, very good. Hey, Joe, I would like to enter what we call a rapid fire round. And I'm going to ask you a couple questions. I'm sure you're pretty good on impromptu stuff. It's not a pass or fail, and I'm sure you have some good answers for this. I got about 5 questions for you, and you can answer them in less than a minute. You ready?
I hope I can do it.
we have faith in you, Joe.
We do.
I just finished a board meeting when you guys called.
You're ready to go then.
All right.
All right. For spinal health, let's say name one exercise that every fireman should do to stay healthy.
I would say endurance training on a Roman chair.
Ooh. So what would that look like, Joe?
We actually have proof for that. We've done several studies. Let me know. Send me an email. I'll send you guys. But if you can increase endurance, there's a high likelihood you decrease injuries within a year, and you don't end up getting medical treatment within the year. And you can measure it. It's called the Buren-Sorensen or isometric test. You can measure endurance, work out your endurance, and then be in that zone where you prevent injuries.
Terry, make sure we put that in our email to everyone. Joe, I hope the rest of the questions are answered that beautifully. All right. For every person who sits at a desk, name one exercise they should do every hour to keep their back strong.
They would want to correct their posture. So military posture sucks. It doesn't feel natural. But even me right now, I'm leaning forward. By the end of the day, I get pain. Now I can work out all I want. I can get trigger point injections. I can get manipulated. That'll give you temporary relief. But you have to correct that postural syndrome. It's the easiest thing to criticize. It's the hardest thing to get done or accomplish.
Beautiful. Most common mistake every business person does in their every mistake a business person does, and if you can provide a solution, quick solution.
Sure. I think, most businesses, including ours, it's going to be labor costs and rent, right? So you better figure out a good model for your treatment approach and your reimbursement, so you're making enough profit and making sure you cover your rent and your salaries. I mean, that's the basic thing in business. And from there, you can develop your marketing strategy. I didn't have a strategy when I started, but it worked out. But make sure you have a strategy for marketing and your salaries.
Beautiful. Perfect. What is one change that everyone working from home should do right now? And that's kind of an open-ended question, so fair game.
Recharge. I've been involved with business. I'm a workaholic, but in the mornings I've been waking up, I've been taking leadership courses, and I recharge, because that's one thing in business we don't do. We don't recharge our bodies, our minds. So in the morning, get up a little bit earlier, relax. I do some meditation before I have my coffee. Think about your day. How are you going to plan out your day? And then have a strategy for your day, and then work out. You got to take some time to work out, either in that morning, I do it in the evening, and make sure you recharge your mind and your body.
Joe, yeah, I'm broadcasting from South Florida, and I would love for you to move here, and we could be training partners. I love everything you're saying.
And just to let you know,
Last question.
Just to let you know, Joe, Spencer gets
sorry.
up at 3:30 in the morning to do his recharging and workout. So before you move there, understand that he's a 3:30 in the morning guy.
I'm a late guy, so we're gonna have 2 workouts.
we may be crossing in the night there.
No, seriously, when I first heard about this recharging your body and your mind, I thought, oh my God, who's got time for this crap? I'm working, when we started our clinics, and even now I'm working 12, 14, 15-hour days. You guys all know every chiro has their own business.
Yeah.
And then you're hiring kids out of school, and you say, hey, can you work on a Saturday? Here's your salary you agreed to, $90,000 a year. Oh my God. Can you work on a Saturday? No, I can't do that. So I thought, how in the hell am I going to recharge? But I'm telling you, it changes your life, and it helps with family. It helps with everything, your business. Everything.
Agreed.
Yay, Joe. Love it. Last question, number 5. Simple. Best core exercise. Now, I know core is used so loosely. So you tell me, what would be the best core strengthening exercise?
Well, again, we're into high intensity training. And for example, I work out with our best referral sources twice a week. I have several surgeons that work out with me. I work them out,
Wow,
and
that's great.
we do basically kettlebell deadlifts, and we do crate lifting. And I'm telling you, if you are questioning the definition of core, do that with
Yeah.
60, 80 pounds, and then tell me about it.
Fantastic.
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 You passed. See, Joe, that wasn't bad at all, huh? Hey.
No, I need some coffee, but yeah, it's good.
Well, on that note, the past few years, people like you talked about in pain and in discomfort and all that. In the past 2 years, people have been in a lot of pain, both physically and mentally. What's your thoughts on the psychology of pain?
Well, it's interesting that you say that. We're developing courses right now for all our staff on psychologically informed care, right? And Dr. Matheson has a lot to do that. He's a psychologist. Also, John Mayer has a active study right now that he's involved with the DoD, and they're looking at psychologically informed care versus traditional care. And chiropractors are doing this already. Half of your practice that you're doing, you're a psychologist. You just don't charge for it. But the way that it is very important is to involve outcome measures. That's another thing. We do use a lot of outcomes like the Bjorn Sorensen, the trunk endurance test as a performance test. But, people do, for example, the oswestry, but they don't really use those questions as a tool. And so, for example, if you tell me, I can't sleep, I can't lift a grocery bag, I can't travel, I don't have social life, and you're just manipulating and doing your exercises and just redoing the oswestry, but you don't put that as your goals, you're not doing psychologically informed care, and you're not measuring it. And so it seems very simple and very pragmatic, but most people haven't framed it yet. You're doing different components of that. And then the next couple of years, what we want to do is we want to really empower our treaters to be able to master that. Because if you don't address sleep, what happens to your pain? And if you're not addressing travel and their social issues, what happens to their pain? And so that's what we're doing, is doing that and then measuring it. There's a lot of different measurement tools that you can use. In addition to that, beyond that, what we see the future as with regards to research is we just finished a large study. Unfortunately, COVID hit and our N went down. We were looking for 1,500. We ended up with 450 in our total participants, firefighters. But also do screening. As a chiropractor, you want to hammer, and you have a nail and a hammer, you're going to hammer that nail as hard as you can. That's all you're going to do. But also triage and see what the risk factors are. So like with these firefighters, we did analysis risk factors on their sleep disorders. We found out 98% had sleep disorder. It's very prevalent. From there, depending on your risk factors, you were delivered a certain amount of care. So some of them got education, some education and exercise, some education and a very specialized Navy SEAL watch that monitor their caffeine intake, their sleep disorders. And then from there, we even paid for them to have a consult with a medical doctor for sleep disorders or a CPAP study. From there, we did obesity, and we did the same thing. Depending on your risk factor, you got certain level of interventions. And then for back pain, we did the same. We had an educational video, we had workouts, all the way to treatment with a chiro or a PT. And then that way you can allocate your resources better. But all this is going to take time to formulate and practice. But as a private practitioner right now, you can start implementing some of these psychologically informed approaches and more patient-centered care approaches. We have a tendency we're going to do a report of findings, and we tell them, here's the x-ray, and here's the, degenerative disc disease, which is that really a disease? And then you tell them about how special you are and how great you are. But you forget to ask them, like, why did you come in? What's important for you? Well, I can't raise my arm above shoulder level and I got to do this. Well, you better measure that. You better implement it. Or, I don't like Pilates. By the way, a lot of people are not going to like this. I can't stand golf. But if it's important for my patient to golf, I'm going to make sure I get them golfing. And so you got to do that informed patient interaction. But you need some tools to do that. You need some outcome tools to use and incorporate and get into that patient-centered approach where it's also a negotiation. Now, within that negotiation, you're going to be open-minded, but you're also going to steer them away from things that are not evidence-based, right? So if they tell you, oh, they told me that if I do this and, drink essential oils a gallon a day, I'm going to get better. You'd say, no, that's incorrect. That's not true. And steer them towards things that are more favorable for a good outcome.
Terry, I don't know where you found Joe, man, but I love this guy. No wonder why you're doing so well with all these facilities. Because one of my comments to you was really about evidence-based care and how in 1993, when it was first introduced into the healthcare system, it actually failed miserably. And before evidence-based, it was intuition-based medicine. The old guy that would visit your home, the doctor with the stethoscope and the black bag. And, he only did as well as how many years of tenure he had in healthcare, But now, now we're learning that there's a new approach, and you actually described it beautifully without maybe even realizing it. And it is really considered interpersonal medicine. Interpersonal medicine is based on three areas: circumstances, capabilities, and what was the other one? Preferences. And so you're really dealing with the patient as a unique entity, and everyone gets treated more specifically. And obviously that's what you have picked up on. So how do you feel about evidence-based, especially as someone involved in all the research that you guys do?
Well, look, evidence-based has its place. And I think the most thing that you have to realize is that it's reproducible. So if we do a research study, they're very strenuous. Right out of school, I got an NIH grant, which I found out later that it was impossible to get. If I had to do it over again, I would have never wrote it. And I went through heck doing that. That's why I hired a PhD when I noticed that I didn't know enough about doing the grant. I got lucky and I got this NIH grant. From that grant, we published in Spine, we published in Archives of Physical Medicine, different things. But what I can tell you is mixing both is correct. And then knowing when you're not using something evidence-based, you don't have to be ashamed to know that, understand what you're doing, right? Now, if the patient, you're going to use cupping because that's going to get that patient to do that deadlift, I could care less. But don't be confused that doing cupping alone is going to get that patient better. And so, you have to understand that many things too, when you do research, work in the lab and they don't translate to clinical implementation. We work in Australia quite a bit in the early 90s when I first started. And that's where all the transverse abdominis activation came in, and multifidus activation, and doing EMG at the multifidus level, and then having the patient do exercises to reverse those findings. Well, we found it was impossible to do EMG in the clinic while you're seeing patients every half an hour. So some things you can't implement, but evidence-based research is reproducible, and it's something that you can explain easily and combine with whatever techniques. And the great thing is that manipulation was so scrutinized that it essentially proved that it works. And so there's ample research to show that manipulation for acute pain works very well, subacute, and even now there's some studies showing some chronic impairments that are helped with manipulation. But again, being interdisciplinary, I always mixed it with other disciplines, and sometimes definitely with exercise, because how do you maintain that?
Joe, how long have you been practicing?
I've been practicing since 94.
Oh, okay. So you remember the good old days of insurance and
Yep.
reimbursement.
I remember when ASHP used to pay us like $80.
Yeah, you remember that?
Yeah.
And then once they got us all on the trough, and okay, we're going to pay you
Yeah.
25. And by the way, you can only bill for manipulation. Right. And it's really against my principle because I've always combined exercise.
Yeah.
So, but let me ask you though, because we were always under the microscope And there was always a show me the evidence or show me the research. And I laugh now because there's more research on spinal manual manipulation than any other medication, any, prosthetic, anything like. And so now, not even the osteopaths have done work for the chiropractors in a sense that their published research just quantifies what manipulation does. So there's so much evidence out there on it. What do? You take the evidence and then you implement the patient's particular circumstances. So you might do a protocol, a procedure that is evidence-based, and then add something else.
I would keep it simple. So figure out the way that you practice and then look at different techniques and different things. And what we do is phasing. I'm telling you, if you overcomplicate it, it's too difficult. And then what we also, when you do a history, if they've done, uh, very low level, that's what we see all the time. Our spine patients are stuck in phase 2. They've been doing the bird dog, they've been doing bridging, superheroes, getting manipulation, and they've done 80 visits and there's no change, or they get temporary relief. Well, I have a discussion with the patient like, hey, we have this high intensity training, there's research behind it, it's difficult, you're going to be sore. As a matter of fact, when you walk out of here, it may feel like you have a knife stuck in your back, but we're going to work with you very closely, and I'll be the first one to stop the protocol or change it if I see that you're decreasing your range of motion, you're not able to do activities, and we measure that. And so that would be an example where you're phasing something and then you're changing it, because if you give them the bird dog and the superhero, and again, by the way, I'm not downgrading those exercises. They're very good for somebody who's very debilitated and doesn't centralize, or somebody who had a surgery recently, but they're not very good for somebody who's very active and is already way above that level. And we've done, Childs did a study in the military. He's a very famous physical therapist, PhD, and they try to do low level interventions in the military, and it helped nobody. Because if you look at the military, what do they do for training? So then laying down and tilting your pelvis or hollowing your stomach is going to get them to get rid of their back pain. I mean, he knew that going in that wasn't going to work. He's not a dumb guy. But, pick the intervention based on where they are. And then what I try to do is find things that weren't done before. If you have a patient, they come in and they haven't done manipulation, gee, what do you think I'm going to start with? I'm going to explain to them the evidence. It's very safe. It's very safe for the neck. It's very safe for the back. I also explain to them how I'm gonna perform the procedure, and then ask them what questions they have. And then from there, if I notice that they weren't doing high level exercises for spine, then I incorporate those. And so when you do the phasing and the history, you can do a more constructive plan. And it's not hard. You just keep it really simple, and then measure what you're doing, because that's great that you can palpate. The other day, somebody told me they could palpate an SI joint. I'm sorry, I'm a researcher. It'd be the same for me telling you I could palpate kidney stones. You're palpating this, the PSIS. I'm sorry, my friend. And the patient had a fusion in his hip that wasn't picked up. So you just have to kind of prioritize and then develop the plan of care based on what wasn't done before and based what stage of care they are, right? And that's worked well for me. It doesn't mean that you have to do it exactly the same way, but that's what we try to do, is standardize the care, because we want to reproduce it just like in research, right?
And Dr. Terry and I, our specialty being in sports, it is really imperative that we measure, because that's what athletes do all day long. They measure speed, strength, power, stamina. So when we can measure a before and after an adjustment, before and after therapy, before and after weeks of it, that's everything. But so many people don't do that. I don't understand why we
right. And athletes, it's crazy now. They have companies that just do that. They have mobile vans that go in. We just finished a management deal, because we also do management deals just like we did in Thousand Oaks. But we had a large management deal with Dr. Cyclin Benny. He's the doctor for the 49ers, and the Giants. And so we developed the concussion clinic there. So we had to develop measurements for concussion and rehab for concussion. We had to develop different measurements for athletes. They bought into the trunk endurance and neck strengthening. Now, the Giants and the 49ers, the Giants and the 49ers have their own physical therapy, but also he was the team doctor. So we did pull some chronic pain patients from there. And in sports, it's a whole different world. I mean, right now, they know exactly what a heat map is. They know, my favorite football player is Lionel Messi, right? I'm from Argentina. I'm from Rosario.
Oh, that's where that accent is from. Okay.
And they're gonna know how many times he kicks, how much he sprints, because you guys know that you're gonna use that information to be able to enhance performance, or if he gets injured, that's your baseline, right? And now they measure everything. They have the little GPSs,
Yes,
right?
yes, yes.
And they put them on their shirts, and they know exactly how high they jump, what they throw. They look at sleep, they look at everything. But it's not that complex. You could do it with some of your patients. Dr. Mooney embraced the industrial athlete concept, and so for workers' comp and for Medicare patients, we tell them that we're going to treat them like an athlete. We're going to measure what they do. So if you have a patient that needs to lift 50 pounds, what's the best way to know if they can lift 50 pounds? Yeah, and if we do some performance tests, and then we see, and we actually can graph it, and you can bill for that information. So we can graph. Right now, they have a medium to heavy job demand from 20 to 50 pounds. Right now, they can lift 30, and we're going to do this intervention for this long, so we can get them to 50 pounds and return to work. We can measure back endurance. We can measure plank tests. We do plank tests. We do back endurance. You guys do a single leg hop. You do functional movement screen for squatting for different movements. And so all these things are measurable, and then you can actually show the individual. And we've developed software that actually prints a report card. So I can say, look, this is you now. Normal is here. You're missing like 50. You have a 50% deficit, and we're going to do this, and your back's going to feel like you got stuck by a knife, and it's going to be horrible. But we're going to get that 50% back, right? And so now I want you to put that on your fridge, and that's why you're going to walk 2.5 miles a day. We're going to get you to 3 miles, and we're going to get you to do a lot of homework, and then we remeasure that. So just like you guys are doing in athletes, I would encourage to find some things, simplify it, don't make it complex, and do some measurements on your patients, because it's easy to explain that. And it helps anything we can use to motivate a patient, whether it's a work comp patient, whether it's a motor vehicle accident, whether it's a Medicare patient that decondition. Those are all things that can really help you as a tool. It'll make you a better practitioner. You're a great manipulator. You're doing really well. I'm not saying that you're not, but it's just some tools that can enhance what you do.
Fantastic.
Oh, that's fantastic. Yeah. No, I appreciate that.
Joe, in closing, we could go so many different directions with you. I mean, good Lord, we love having super brains like you on the show, because to inspire everybody to be better. And I really appreciate that. And on that, would you like to address the importance of, to the average person or the healthcare worker, what are some things you'd like to address that you see in society, that the common mistakes you see all day long? Is there anything you'd like to address and to speak directly to them of things that they can do to improve their health?
Yeah, definitely for patients and for practitioners, one of the things that you see is the dosage of exercise. A lot of people develop a prescription for exercise based on preferences that they like, or preferences that they have, or misconceptions. And the dosage is very specific to that patient. So if you don't measure, you have a blindfold on. How do you know what they did before? How do you know what they can do now? So you really have to develop a plan of care, knowing what their previous level of function is. And the best way to estimate that is through the history exam, and do some performance tests, and do some outcome tools, and then get their level now. And then that delta is going to give you the prescription. From there, you want to dose it correctly, because again, one of my pet peeves going through even our clinics, a lot of times they're giving somebody very low level exercises and expecting a different result. If I have to lift 100 pounds and it's a chronic injury and I've been there before, yellow TheraBand doing monster walks not going to do it. On the or my favorite, clamshells. Unless you're a clam or you like clam chowder, but, good luck for back pain. But being facetious, right? But the other thing that you have to be careful is you don't want to injure the individual and you overdose them. Now that's rare, but I have seen that a few times. And so I think if anything is find the right dose of exercise and intervention. How many, what's the frequency and duration of your manipulation? Things like that are very important.
How much time does a patient typically spend with you guys?
We do about an hour. So we do about an hour of care. Some patients may do an hour and a half. Some patients will do less than an hour, but we focus on about an hour of care, unless we're doing work conditioning, and then it could be 2 hours to 3 hours.
So will you adjust the patient and then move them to the physical therapist? Is that,
the chiropractic, yeah. In the chiropractic practice, actually the chiropractor does his own exercises.
Oh, cool.
Because
very cool.
I work out right next to the patient. I like to get involved. Again, I'm not saying that it's right or wrong. If you want to manipulate 100 patients a day, my gosh, go ahead. If I saw more than 15 patients a day, I would hit my head against the wall. So, that again, that's just the way that we practice. It doesn't mean, so on average, we're seeing about 12 patients a day. That's our sweet spot.
Mm-hmm. There you go. Great to hear. Well, that is a beautiful wrap up. I can't appreciate you more for giving some novel approaches and perspectives on multidisciplinary care, on evidence-based, and even personal type care. You definitely stand out in the crowd, so I appreciate you, Joe. Thank you so much.
Well, thank you for the opportunity, and again, it's not me. I think everybody has their own unique things that they do, and keep doing it. That's all I want to say.
There you go. Well, thanks for being on our show, Joe. We appreciate you, and I guarantee you we're going to ask you to come back to give more insight because you're fantastic. So have a blessed day, man.
You too. Thank you very much.
Thank you for listening to today's episode of the Crackin' Backs podcast. We hope you enjoyed, and make sure you follow our Instagram at Crackin' Backs Podcast. Catch new episodes every Monday. See you next time.